Are we good? Is there somebody ready? I'll just start, shall I? Okay, I think we're ready to start. Thank you very much for coming today. So I'd like to say welcome to the fourth seminar of the 2024 Nursing Event Series. I'm Katrina Lindsay-Smith. I'm standing here today for Kathy Fallon. I'm one of the directors of nursing at the Royal Melbourne Hospital, and I look after nursing inquiry and nursing research. Royal Melbourne is delighted to have joined our partners, the University of Melbourne, and thank you so much, the Peter MacCallum Cancer Centre, for hosting this and presenting the fourth event of this series. I'll begin by acknowledging the traditional owners of the land of which we stand and we meet this evening, Wandura people of the Kulon Nations. I pay my respects to elders past and present. And if you're joining us online, hello. And I also acknowledge the traditional owners of the land where you are watching from. I want to acknowledge our event series partners and the colleagues at the University of Melbourne who worked very hard to bring this event together. So thank you very much. This is represented today by Kathy Daniel, acting head of the department, which is sitting over here, and our colleagues from the Peter MacCallum Cancer Centre, represented by Cara Chapman and Yvonne Hudson. I now warmly invite Dr Di Crellin, who will be our MC for today. Di is a nurse practitioner and senior lecturer and the coordinator of the nurse practitioner programme at the University of Melbourne. She is leading the curriculum development for a specialist certificate in registered nurse prescribing that will be offered by the University of Melbourne to provide an education pathway for registered nurse endorsement for scheduled medicine prescribing, which is so exciting and for us, I think, really overdue. So thank you so much. I now welcome Joy to join me. Thank you.
Just to advance these because we're a little bit behind. So thank you, Katrina. And again, welcome to everyone who's joining us here this afternoon for what I think is going to be a really fabulous seminar and a really interesting topic. And it's a great way, I think, to finish the year and the seminar series that we've had this year, which has been fantastic. It's kind of really my pleasure actually to chair this seminar because I've had a long-standing interest in registered nurse prescribing since 2014. I think it was about 2014 when I was involved in some work with Health Workforce Australia, mapping the health practitioner pathways for prescribing nationally. And today, a decade later, our seminar focuses on the progress that's been made towards making registered nurse prescribing possible. And it's potentially imminent. I think this is going to be, one of the most significant regulatory changes we've seen for quite some time for nurses, probably since national registration was introduced in 2010. And it's also going to bring us into line with other countries where registered nurse prescribing has been in place for many years. So we're, as you kind of alluded to, Katrina, we're a little bit behind the eight ball. Our colleagues in New Zealand are well advanced in this space compared to us. And so for this seminar, we've brought together a fabulous panel of people to help us understand what's being proposed in terms of registered nurse prescribing, what the regulatory changes are likely to look like, and what the implications of this really quite significant expansion to registered nurse scope of practice might mean for Victorian healthcare. And then we've also got some examples to illustrate just how, if we introduce registered nurse prescribing and specifically, medication-related prescribing, what might that achieve for improving access to healthcare for populations of Australians who miss out a little bit? And specifically, we're going to focus on aged care and regional and rural Australians. So to get started, I'm really excited to introduce our fabulous panel. We've got four panellists who will all speak briefly, and then we'll have an opportunity for questions afterwards. Our first speaker is Leah Bradley, who's currently a Senior Project and Policy Officer at the Australian Health Practitioners Regulation Agency. Holy dooly, I'm not done yet. Nursing and Midwifery Board of Australia. Leah has over 30 years clinical experience and has practiced in various clinical areas. Her areas of interest and research focus are professional experience placement, supportive education, curriculum design and transition to practice experiences of students, graduates and preceptors. Leah's role at AHPRA and the NMBA includes the designated RN prescriber project and the RN standards of practice review. So I think she's really well placed to introduce us to the proposed regulatory changes. Our second speaker is Cara Garrett, who's a clinical nurse consultant in residential Inreach, so our aged care sector, at the Royal Melbourne Hospital just across the road, and one of our partners. Cara has a long and varied nursing career working in New Zealand, the UK, and for the last 13 years in Victoria. She has a strong interest in advancing nursing practice and is eager to see the anticipated regulatory changes to legitimise advanced practice roles such as hers. In her role, Cara attends acute healthcare events to prevent unnecessary hospital presentations and admissions. She does this independently with only telephone access to medical specialists. And so I think she's going to share with us how extending her scope to include prescribing would positively impact her patients and the residents in aged care. Oops, sorry, that's me being a little bit dumb with the mouse. Our third speaker is Carmel O'Kane, who's a cancer nurse practitioner at Wimmera Healthcare Group. And Carmel's been a cancer nurse since 1995. She managed the Peninsula Healthcare Cancer Service until 2011, when she moved to Horsham as a nurse practitioner. Carmel has been working in this position in quite an innovative role, providing education, support and clinical excellence in cancer care to the Wimmera region of Victoria. Carmel has a particular interest in patient decision-making as well as rural cancer nurse education and supportive care, and is going to provide insights to how RN prescribing is likely to complement NP roles rather than supplant NP roles to improve regional cancer services and the delivery of healthcare to regional Australians. And then finally, we'll finish with Emma Saddington, who's a critical care nurse with over 2 decades of experience. She's a strong advocate for global emergency nursing and serves as chair of Children of Cambodia, supporting sustainable primary education in rural Cambodian communities. Emma's currently a senior nursing advisor for Safer Care Victoria and focuses on workforce development, policy reform and health system collaboration. And so she's going to explore with us how this regulatory change might impact on Victorian healthcare services and the delivery of healthcare. After our presentation, we're going to leave plenty of time for questions because we anticipate that this is going to actually trigger lots of questions and lots of discussion amongst you all. And for those who are staying on, or there will be catering in the foyer for people who want to continue that conversation. There will be another chance to snap this, but grab the QR code or the code because for those who are online, because we will be fielding questions and we've got somebody manning that online, but we'll have roving mics for those people in the room who want to ask a question or make a comment. So I'm going to ask Leah.
Okay, so thank you everyone. My name's Leah Bradley. I'm one of the Senior Policy and Project Officers with AHPRA and the NMBA. Thank you for allowing me the time to talk with you today about our proposed registration standard, the endorsement for scheduled medicines, registered nurse prescriber and the proposed supporting guidelines. I've got my notes here because I had to shorten a 17-minute presentation into a 5-minute presentation. So, and I was advised to wrap it, but I didn't think that was appropriate being part of a representative of AHPRA. So the prescribing journey started a long time ago in 2017, and it started at a national symposium where the Australian Department of Health for the Australian Government and the Commonwealth Chief Nursing and Midwifery Officer held a national symposium to really explore designated RN prescribing in Australia. And an outcome of that symposium was overarching to a support to develop a prescribing pathway that would see appropriately trained and educated nurses be able to prescribe in Australia. So that led to, in 2018, the development of the draft standard and guidelines that went out to public consultation in 2018 and 2019. So you can see it hasn't been an overnight journey. And as this has a regulatory impact, the Nurses Board and AHPRA were required to go out to further consultation with their stakeholders in the form of a consultation regulation impact to really analyse the costs, benefits and impacts of the regulatory proposal and the options put forward in that consultation regulation impact, and to see really how that that regulatory standard would work in practice. So we emailed our 41 key stakeholders, and we received, and we published on the NMBA newsletter and the AHPRA websites and various other methods. And we received 109 survey responses and 24 written responses to that consultation regulation impact statement, which really led to the development then of the requirement for a decision regulation impact, which is required by the government to be put forward, or the preferred option to be put forward to health ministers who actually represent the national scheme. Both of these were required to be passed as compliant. So the consultation regulation impact statement was passed in 2023, and the decision regulation impact statement was passed in 2024. And that's now led to the progression of the proposed standard and guidelines. So we need to keep that in mind, that it's still under proposal, being progressed to the health ministers for feedback and approval. So you can see it hasn't been an overnight journey. So this slide outlines the proposed registration standard, and under section 94 of the national law, the National Board may endorse the registration of a registered health professional who's registered in a health profession for which the board is established as being qualified to administer, obtain, possess, prescribe and supply scheduled medicines, only if they have an approved qualification relevant to that endorsement, so a board approved qualification relevant to that endorsement, and they're compliant with the registration standard relevant to the endorsement. So I guess what that means in layman terms, and I'm still learning the national law, is that anybody who is undertakes approved NMBA education and meets the requirements for the endorsement will be able to prescribe Schedule 2, 3, 4 and 8 medications in collaboration with an authorised registered health practitioner. So that being an autonomous prescriber, so either a nurse practitioner or a medical practitioner. These nurses will also be required to meet the requirements of the designated registered nurse prescriber endorsement as set out by the proposed standards and guidelines which have been set out by the NMBA, and they're all readily available on the NMBA website for you to have a look at. That also need these nurses who are approved and endorsed or approved for endorsement would need to be responsible and accountable for prescribing within their scope and clinical context within a governance framework that's set up by healthcare venues and approved by the health organisations. So what are the proposed requirements for the endorsement? You'd have to be, you obviously have to be a general registered nurse, and you'd have to have no conditions on your registration. You'd need the equivalent of 3 years post-registration clinical experience or 5,000 hours. And that is within the 6 years for when you apply for the endorsement with the Nursing and Midwifery Board of Australia. And you would have had to successfully complete NMBA approved units of study, or the equivalents of NMBA approved units of study that lead to the designated nurse prescribing endorsement. And what I can tell you is that the registered nurse prescribing accreditation standards, it's quite a mouthful, all of these words. So they have been written. They're not formally published, but once they are, higher education providers will be able to write their curriculum mapped to the accreditation standards. But until the actual proposed registration standards and guidelines are approved by the health ministers, they won't be endorsed by the Nursing and Midwifery of Australia. What I do know though, and Di will understand this, that all approved courses will be clearly mapped to the national prescribing competency frameworks, and that supports safe prescribing by defining the competencies necessary to prescribe medicines through each stage of the prescribing cycle. So this next slide, and I think Di has mentioned too, the health professionals prescribing pathway, which was introduced by Health Workforce Australia in 2013. And really outlines a nationally consistent approach to the prescribing of medicines by health professionals other than non-medical practitioners who are registered under the National Registration and Accreditation Scheme. So the health professionals prescribing pathway sets out the safe and competent prescribing by health professionals. So you can see here there's 3 models, and this is from a very early draft of ours, but we have RNs who can prescribe by protocol and standing order. We've got the designated prescriber who would need to prescribe with an authorised registered health professional, so either a nurse practitioner or a medical practitioner. They would need to undertake postgrad certificate qualifications, have a clinical, there would need to be clinical governance in a framework in place at the organisation, and a key written prescribing agreement between the designated RN prescriber and between the authorised health practitioner that is actually approved by the healthcare venue, as opposed to the nurse practitioner who is completely autonomous in their prescribing. So that's a very brief outline of the differences in underlying models that really differentiate between the RN, the designated RN prescriber, and the nurse practitioner. So there's also proposed guidelines that sit with the standard and support the standard, and that includes the requirement for a governance framework. That governance framework is clearly outlined in the board's guidelines, but really that sets up the prescribing agreement and the roles and responsibilities of the designated RN prescriber, the healthcare organisation, and the authorised health professional. They would also need an active prescribing agreement to be in place, and this is a key written document that outlines the roles and responsibilities, and that would also need to be approved by the healthcare venue or employing organisation. And specifically for designated RN prescribers who have been approved by the board to have the endorsement, they would actually need to undertake a 6-month period of clinical mentorship. So not clinical supervision, because these aren't students, they're not re-entering into practice. They're educated to prescribe competently, but the clinical mentorship just enables that 6 months for them to develop competence in prescribing. So the nurse practitioner or the authorised health practitioner, or both, who are supporting the designated RN prescriber, would tailor that mentorship to the governance framework, to the prescribing agreement, the policies and procedures of the healthcare venue, the drugs and poisons legislation, and any other policies and procedures that are part of that governance framework. And I guess last slide, 1 minute, I've got to talk very quickly. It's a bit of a big jigsaw puzzle, and I was just talking to Emma about, it seems weird that we're doing this when there's other pieces of the jigsaw puzzle that still need to roll. So the AHPRA and the NMBA have written the proposed standard and the proposed guidelines. However, a lot of these other pieces of the jigsaw puzzle are beyond the regulatory remit of AHPRA and the NMBA. So there needs to be broader system changes to occur for successful implementation across healthcare. And I've included accreditation there because accreditation standards still need to be published. Education providers obviously have to write curriculum to meet those accreditation standards. Registered nurses have to be incentivised to undertake those courses. They need to then apply for the endorsement. Government needs to review the MBS and the PBS. Public and health consumers need to have the role of the RN designated prescriber socialised with them. And healthcare and industry need the capacity to be able to have nurse practitioners and medical practitioners who want to be a clinical mentor to these designated RN prescribers. And they'll also need the capacity to set up those governance frameworks as well and have a writing agreement or a written prescribing agreement, which hopefully they can build already, well, they've already got governance structures in place that they can build on. I've put the chief nurses, the drugs and poisons, that's very important too. So there needs to be harmonisation of the drugs and poisons legislation. So hopefully this is a catalyst for that to occur. And I know there's a lot of work being done in the background. And we've also, the NMBA has also included the chief nurses because they will be really integral to the success of implementing this in their jurisdictions across healthcare. Because as I said, a lot of these things are beyond the regulatory remit of the board, although we're very supportive. There will be differences in implementation strategies. So I just wanted to, I know I've only got 1 minute and that is it. And I guess we need to keep in mind that this is a great innovative change that Di said, but this will hopefully enable safe, timely and improved access to medicines for communities. It will promote workforce flexibility and really it will allow those registered nurses who want to work to the top of their scope. And the research says when you work to top of scope, you get greater job satisfaction. And it also has the potential to improve the coordination of care in rural and remote Australia, and particularly for our communities at greater risk, such as our Aboriginal and Torres Strait Islander people. And I've become aware just quickly of a great research project that you might be interested in. And it's about, because I think for a lot of healthcare venues, this is a big implementation strategy. So there's some work being done by a conglomerate of universities about advancing the implementation of designated registered nurse prescribing, specifically across healthcare contexts and venues. So I thought you might like to keep that slide. The project team's currently finalising a manuscript that they're going to publish about the enablers and the barriers. And in the future, the project team will be actually working in partnership with health services across Australia to trial implementation strategies across multiple healthcare venues. So that might be something that you're all interested in, having one tool that's adapted to different venues. So thank you, everybody. And I'm sorry I went over time.
Thank you. Thank you, Leah. I think you've given us a great background to this, and I'm sure that there'll be plenty of questions for you afterwards. So thank you for that. Our next speaker is Cara, Garrett. Oh, they was right in front of me. Blind, completely blind. And Cara's going to share her experience as an aged care registered nurse and what it might look like if she had prescribing rights.
Hello, thanks, Di. I'm just going to talk a little bit about, oh, shall I?
Yes.
Keep going here. Oh, here I am. Talk a little bit about residential Inreach, which I think I saw Melissa. Here's Melissa. She's one of the pioneers of residential Inreach, and really it focuses on the very frail older people who really are sort of neglected. We're not in the press. And we really do make a major difference to them as a population in improving their access to medication, to healthcare. And our team, we respond acutely, we go into the nursing homes, we do advice for the nursing homes, and we make plans and care for these residents. So my case study is really around one of the situations we find in residential Inreach where we get the most stress, and that's around managing symptoms of dying. Maria, she's 91 years old, and she was referred to us with hypertension and hypoxia. She actually had goals of care A. She had come to the nursing home only 8 months earlier. She had lived in her own home up until 12 months ago. And then she had a fall, broke a hip, broke a humerus, lots of complications while she was in hospital, deliriums, went back home to her own family. They couldn't deal with her increasing needs, and she was then placed into a nursing home. And during her time at the nursing home, she had some quite significant functional decline and some cognitive decline as well. And we were called in because her blood pressure, she had a systolic of 60, and she was hypoxic of 90. She had some restlessness and agitation. She had chronic pain. The GP had recently stopped a Norspan patch because of drowsiness, and nothing had been prescribed to replace that. We felt she was dying, and she had a high chance of dying within a few hours to days. The family, of course, with their goals of care A, needed to be prepared for that. And that's a big part of our role as CNCs when we go in, was talking to the family and helping them to understand where their mum was headed and understand from their point of view what they wanted. The family mainly wanted her to be comfortable, and so did we. She was exhibiting a lot of pain. She was agitated, and we wanted her to have some morphine and clonazepam. So the challenge for us is we don't have necessarily have a doctor with us. Occasionally we do, but in a rare situation. So mostly it's on the phone. So we can do a telephone order, which has its limitations. Some nursing homes will have stock that they can use on impressed, others won't. Different ones have policies around you're not allowed to use that even in an emergency, so they'll need a prescription as well. So while we can get a telephone order, we can't necessarily get that prescription. We can access GPs or locums. There's often long delays, and when someone's dying, we don't have hours, can't wait till tomorrow. We really need it within a timely time frame. RMH at home acute are really great. Often we refer to them. Their registrars are fantastic. They will often, if they've got capacity, do that prescribing for us. But it can actually take up to 24 hours before a prescription could actually be available. VVED, I don't know whether you've heard of them, the virtual ED, they're also really good. Double handling of the resident and family is the biggest issue. So while we've just spent 2 hours with them, contacting VVED can double handle. In this case, I actually did a telephone order, said, could we start some morphine now? And the RN went to do that and came back and said, oh, we actually don't have any. I thought we did. I then had to find a prescription. We checked with the GP was unavailable. Hospital in the home was at capacity. They had doctors off sick. They couldn't give us a prescription. So we contacted VVED. VVED are very good. They have an end of life palliative care stream, but we queued for about 10 to 15 minutes. They then did their own assessment, talked to the family, assessed the patient, talked to me, and then they were able to provide an interim drug chart. Unfortunately, it took 2 hours. So it was 2 hours before Maria was able to get access to that medication, and we still had to get it from the pharmacy, which is a whole nother story. So it would be a game changer, I think, for us in residential Inreach to be able to do our own prescribing. It could have been done within minutes. We could have faxed through to a pharmacy, and she could have had access to medication in a timely manner. Thank you.
Thank you, Cara. I think that was a beautiful illustration of how RN prescribing could make a huge impact on people who have really poor access to medication. So thank you, that was fantastic. We now have Carmel O'Kane, who's also going to share a slightly different perspective. Oh, sorry, no, I leapt ahead because you'd already advanced for me. I should pay more attention, shouldn't I, to the slides? And Carmel's going to give a similar illustration. Thanks, Carmel.
Hi, and thank you very much for inviting me. This is really exciting. It's a wonderful initiative, and as has been said, well overdue. Did that work? So I live in the Grampians, live and work in the Grampians region of Victoria. We cover a very large area. Grampians Health recently amalgamated and covers Ballarat, Stawell, Horsham, Edenhope and Inboola as campuses of Grampians Health. We cover very, very large area in Western Victoria. It's a beautiful place to live. We choose to go there for a reason. It's beautiful. There's so much to see and do, and it's a lovely place to live. However, it's a large area. So in 2021, we did a telehealth project that was just looking at how much we could save people travel by doing telehealth rather than face-to-face. With just 100 visits, we saved our patients almost 61,000 kilometres, just to show you just how far people are travelling. That's actually equivalent to 4 times around Australia, and that's only 100 patients in 1 year. Made a phenomenal difference. Remember, our patients are elderly, They live out on farms, there's no public transport in the area. You can live in Edenhope and still be half an hour from the hospital in Edenhope because of how big farms are out there. People don't like to travel. They certainly don't like to travel to Ballarat or Melbourne. It's very scary for them. So it's really, really difficult. GPs are few and far between. It can take up to 4 weeks to get a GP appointment, and it might be a couple of hours from home. Not all of them have full prescribing rights. Many of them are international doctors. They come out to the country because they have to when they first come to Australia to get their registration, which means, you know, they're there for the mandatory 5 years. We start to get them, you know, knowing what they're doing, and then they come down to Melbourne or other places to work, and we get a new lot to start again. As I said, there's no public transport. So it's incredibly difficult for some people. There's one of the patients I wanted to just talk very briefly about. Came down to Melbourne. He's got metastatic melanoma. He only has one eye, and that has very poor vision. He came down to a specialist eye appointment in Melbourne, was admitted to hospital and stayed there for a week or so. Came out with some new eye medication. Told, here's some for you for now, but you'll have to see your GP to get the script for it. Now, it took him 2 weeks to get to the GP, by which time his medication had been used up. He got to the GP who wrote the script. There's none of that medication in the town he lived in, so he then had to travel a 5-hour round trip to get the medication that he needed. So I'm just imagining if he could have seen a nurse at the time that he got home, got the prescription done, the medication can be transported by bus and other various ways, so he wouldn't have had to make that urgent travel. The other last example for me is from Pal Care, where we have patients dying at home with syringe drivers and things like that. Over the weekends and after hours, there's no GPs, there's no nurse practitioners around to change doses. So patients have to wait 48, 72 hours to get a dose increase. And I'm just thinking of a nurse, district nurse who goes out to change a syringe driver, who could actually, based on a plan left by a nurse practitioner, go, you know what, if they've had this many breakthroughs, you can increase the dose to this much, and then it can be written and prescribed and on they go. So I'm just really looking forward to seeing what changes this can make. Thank you.
Thanks, Carmel. As somebody who lives, works and socialises within a 5K radius, so the COVID lockdown meant nothing to me because I don't venture past 5Ks anyway. You painted a fabulous picture for me, and a slightly confronting picture really of the implications of being in regional areas and the limitations that poses to communities, and how this sort of change to scope of practice could make a huge difference. So thank you, that was great. And our last speaker is Emma Saddington, so I'll ask her to come forward, and she's going to talk about this from a slightly bigger picture perspective, but what could this look like for Victoria? Thank you. No, you're fine.
Thank you. Wonderful. Good afternoon, everyone. So can I just start by acknowledging the traditional custodians on the land in which we meet and live today. For me, that's the people of the Wurundjeri lands, and pay my respect to their elders past, present and emerging. At Safer Care, we like to have a really good conversation about being different and how that draws us together in who we are, in what we've experienced and in how we think. And you've certainly heard that today with the conversation and the presentations from Leah, from Carmel and from Cara as well. So a proposed future of RN prescribing. And before I jump into this, can I just really acknowledge the stories that were shared from Cara and Carmel just around the impact, you know, from two populations being the aged care
the care of the palliative patient, and certainly those in regional and rural parts of our state. So the proposed RN prescribing, what was the initial problem statement? And Leah will know this very well, being a lot of work that was undertaken by APRA and NMBA. So to start with, the COVID-19 pandemic probably accelerated, as we all know, the inequities with access to healthcare for consumers further being limited by those lockdowns. The wider impacts across the healthcare sector and the Australian community, which has been that inability for Victorians and for Australians to really access healthcare, and that further accelerated by those that are a vulnerable population, or those that are living in regional, rural and sub-rural communities. There's ongoing challenges, as we all know, around workforce distribution and around people that have got agility in the areas in which they work, not just within Victoria, but across jurisdictions as well. The situation for patients that are living in regional and remote communities is stronger and more challenging than ever. And the stronger rural health strategy indicates that Australia continues to face that significant maldistribution of workforce in these areas. I wanted to just call out a few statistics and a little bit of detail here. So in addition to the challenges and part of the problem statement that you can see online here, the World Health Organization predicts that by 2050, the population will be 1.5 billion, and that will be just those over the age of 65, apologies. Australia's population as of September 2022 was estimated to be at just over 26 million, and 16% of that population was over the age of 65. The implications that our ageing population has on healthcare, I probably don't need to reiterate to anybody in the room here, but it will continue to impact and increase demand both in the acute sector and in the primary healthcare sector. And obviously, our future workforce will be very different to what we have today, and that continues to be an ever-evolving space. So what might this look like? And I want to call out again, obviously, that the conversation that we're having today is all around the proposed RN prescribing and what this could look like as a future. So I've popped up there some impact domains when it comes to the lens of a consumer. So improved access to care, RN prescribing, proposed RN prescribing, will see the support of delivery of care across our great country, whilst acknowledging that there are currently significant challenges in the continued maldistribution of workforce and the access to care. We know that proposed RN prescribing may support this maldistribution further and thus support the access to healthcare in the communities that need it the most. From a holistic patient care point of view, we know that the way that nurses deliver care is very different to many other craft groups. We use that specialised skill set, delivering that holistic and broad lens to the care that we deliver, and support the alternate care models, leveraging on that deep understanding of consumer care needs. And RN prescribing will only allow the deepening and enriching of this care, of this holistic care, both from a social and medical model. Efficiency, and we heard firsthand around efficiency and what that could look like, particularly, Cara, your example in the aged care and the dying pathway there. In our current complex social and geopolitical climates, our modern society is challenged, not just in the way that we access healthcare, but our expectations in the way healthcare is delivered, and for very good reasons. By enabling that the RN prescribed pathway, healthcare teams will be able to look at creating opportunity for that greater streamlining of delivery of care. Consumer empowerment, and, you know, as a registered nurse and a critical registered nurse myself, giving our consumers the most amount of empowerment is certainly important and at the core of the work that we do. Improving health literacy remains a strong focus for healthcare, and our wonderful RNs have got a great ability to articulate this in terms of the patient education and the consumer empowerment. So being able to add a lens around RN prescribing gives that additional holistic view. And then finally, the collaboration and the timely interventions. Nurses are fabulous collaborators. We know that, we see that in everyday practice. So being able to have the registered nurse at the forefront of the patient's care journey and having a lens of the proposed RN prescribing will give greater autonomy and greater support for collaborative partnerships in healthcare delivery and the timely interventions that are required. So what could this look like from an impact domain when we're talking about the nurse themselves? I wanted to pause here, and I have got a slide at the end around our National Nursing Workforce Strategy, which is currently out for draft consultation, and how RN prescribing will support the 4 priority areas in our first Australian National Nursing Workforce Strategy, being valuing, planning, designing and delivering. So overall, we would see advancing our professional growth and our continued involvement as registered nurses and our role and responsibility. The proposal of RN prescribing requires the innovation to continue with the requirement of advanced training and knowledge, which would come with the proposed implementation of RN prescribing, giving opportunities to registered nurses that were never afforded prior. Important, the recognition and the expertise of registered nurses, empowering the registered nurse to deliver around RN prescribing, further acknowledges and values their skill set, their expertise, and their significant value in the healthcare system. The collaboration and teamwork, and I spoke about this from a consumer domain, but certainly from a nursing domain as well. It just gives that further opportunity to foster collaborative partnerships and relationships with healthcare providers more broadly and the communities in which they work. The flexibility of roles and the agility of our nursing workforce moving forward is something that will continue to challenge and engage us and give us great opportunity. And I think with the proposed addition of RN prescribing, that will almost certainly add the value to the flexibility of the role of the registered nurse. And then Leah also beautifully touched on the enhanced job satisfaction that comes with advanced knowledge, advanced skill sets, and opportunities to work in environments that had never been before. Now, I'm conscious of time. I'm waiting for my 1-minute sign, and we had a great conversation before around my lack of ability to keep to time. Laughing at John in the audience there. So I'm going to try and go as quickly as I can here. So what might proposed RN prescribing look like in terms of models of care? Our nurse-led clinics, staffed predominantly by nurse practitioners and registered nurses. Some of these already occur, but certainly the further growing and evolution of these nurse-led clinics. The integrated care teams with registered nurses being at the centre of that, and we've heard firsthand from a regional and older person's perspective what this might look like. The management of chronic diseases, and we know with that ageing population that is only going to become more complex and more burdensome for the healthcare system. And then finally, and we did very well with lots of cross themes here, but the telehealth services that Carmel spoke of, and how RN prescribing could see greater strengthening of that model of care. I guess all of what we've spoken about here draws us back to the initial problem statement and what we were trying to solve. And I think you'll see some great wheels in motion here of what the future could look like. So you heard from Leah, there is quite a large puzzle at play here with multiple key stakeholders across our Commonwealth. and certainly interjurisdictional. We spoke about the CNMO team, so the Chief Nurse and Midwifery Officer team. They're across all of our jurisdictions, our industry partners, and I haven't called out all of them, but just a couple to take note of. The public and community education that would be required, the legislation harmonisation across the Commonwealth, particularly in relation to our Drugs and Poisons Act, and then how does that align to our strategic priorities around healthcare delivery? So, with all of that in mind, and you don't have to answer this question, it's a thought to take home for you. Where could the proposed RM prescribing take you? Where do you want it to take you? And where should it take you? So on that, stay connected. There's details down the bottom, but it would be a miss of an opportunity if I also didn't add a slide around the National Nursing Workforce Strategy. As nurses, we're always about time efficiency and utilising opportunities when we have them. So please also take a QR code of this, have a read. We'll be staying around after the panel discussion. So please come and find myself or any of the presenters for a further conversation. Thank you.
Thanks, Emma. And actually, don't sit down there. I'm going to ask the panel to come and sit up at the front. I think Emma's done a lovely job of just highlighting the issues and why this really, there's been such a lot of work go into RN prescribing. And she's also really, I think, highlighted the value of nursing and the impact of nursing, which is a lovely way to segue into our panel, because I'm not going to say any more, because I want people to have an opportunity to ask questions, because I do anticipate there probably are going to be lots of questions from the audience. For those online, if you didn't catch it before, use the QR code, and that way you can put your questions into the Menti survey. And yes.
Thank you very much. If this, when this RN prescribing goes ahead, there are two possibilities with respect to the number of prescriptions. It stays the same. The number of prescriptions written by GPs goes down, and which is compensated by RN prescribing. That, in my view, is unlikely. What is going to happen is increase in the number of prescriptions. Let's say a conservative figure of 10% increase. Currently, we have 350 million per year prescriptions. 10% increase, 35 million prescriptions more, which means it's going to cost the budget about $3 billion a year. Where is this money going to come from? Because taxes in Australia are already high and acting as a disincentive to work. Where is the money going to come from? So there are medical negatives and financial negatives. Medical negatives, I wouldn't worry. Medical negatives such as increase in prescriptions, polypharmacy, antibiotic resistance. I wouldn't worry too much about it because the individual is taking the risk. They are taking the risk. But financial negatives, where is the money going to come from? If it is not subsidized by PBS, if people have to pay out of their own pocket, no problem. But where is the money going to come from? Thank you.
That might be a question perhaps for either Leah or Emma.
Can you hear me? Yeah, perfect. Thank you. Excellent question. So I'll let Leah talk to the increase or decrease of prescriptions, but I would like to think about a lens of, by early intervention and access to healthcare, I would hope to see that we would see greater health outcomes for patients, less disease burden, less management at the kind of upper echelon of when patients get really sick and their healthcare becomes more expensive and they become inpatients or requiring significant or greater community input. So, I think it's more around what we want to do and where we need to go as a healthcare community is around prevention, and the earlier the better.
Thank you. That's great feedback. Just in writing I wish you girls were available when I was writing the decision regulation impact, because they were great scenarios. But some of the work we did to support that decision regulation impact statement was look at other countries and see if there was a raise in prescription with RM prescribing, and there actually wasn't. But I guess there's not really many evaluation tools available globally. So I guess that's one thing that we will be able to monitor. So that's great to hear that you've picked up on that. Thank you.
Hi, thanks for the talk. I've got a couple of questions. It probably relates a bit to that as well, the previous question around, do you think that registered nurses will be able to apply for a prescribing number, given that I guess the governance structure means that they're only allowed to prescribe within the organisation that they're based in. So I'll let you answer that one, then I'll get back to my next one.
I've had these conversations with the government in writing up the decision regulation impact statement, and there is work being done on the PBS and the MBS, because as far as I know, it will be okay and equitable for patients in public health, but anything outside public health will not be equitable. And I know, I'm sure you've all heard of the scope of practice review, or the Professor Mark McCormick's work now. That's really highlighted the requirements for MBS and PBS changes. So government are working behind the scenes on that.
Thanks. And I guess my second question, it's probably not fully formed, so I probably shouldn't be asking it, but I will anyway. I guess, is this a good opportunity, or to, I guess, look at a professional development pathway for registered nurses throughout? And given that they need 3 years, is it better to maybe align it to a role or a level of practice, rather than just purely a time, like I've done my 3 years, I can now go for it?
I can let you answer that. I'm mindful, I've got my beautiful manager in the room, Jane Motley. So Jane, if you want to add anything, Jane's our policy manager. So that's a really great question. And there's so much flexibility, and there's lots of talk, I guess, with accreditation about leading to nurse practitioner roles, and where can this lead us in the future as professional registered nurses or designated RN prescribers.
John, good question. As part of the National Nursing Workforce Strategy, one of the implementation facts would be around career frameworks. And I think being able to pull in things like RM prescribing will help that career framework. You know, what that looks like yet, I don't know. And it is the great unknown, but it's really around support of the agility in the framework, but also making sure that we've got the right roles undertaking this advanced skill set for the right reasons at the right time.
Can I just check with Bronwyn whether there are any online questions? Because I think, to be fair to the people online, it might be nice to throw to them.
Yeah, it's actually going wild online. So some have been voted up. So I'll start with the ones that have been voted up. Does RM prescribing have a place in the inpatient setting?
Well, and I'm presuming Leah would probably answer that, but I don't see why not. I think, again, as it was pointed out before, I think it's going to be connected to roles and what is required in that place. Certainly in a hospital like Eden Hope, which is a very small hospital run by a GP who is only there week on, week off, I can easily see RM prescribing helping those people that present there at other times. Yeah.
Excellent. The other one that's been voted up is, why not improvised nurse practitioner scope and uptake instead of a nurse prescriber?
Only because of the research done for the decision regulation impact statement, and that was because initially the nurse practitioner was set up, and quote me if I'm wrong, Di and Helen, because I can see the two nurse practitioners in the room, that there are a lack of nurse practitioners across rural and remote areas, and in our communities at greater risk of harm. And so registered nurse prescribing evolved out of one of those national prescribing pathway models where we could have greater access. And then upon talking with nurse practitioners, we talked about the benefits of designated RN prescribers moving further into the role and advancing that role of the nurse practitioner and boosting numbers in nurse practitioners as well.
No, I was just going to say, I think it further goes to support the distribution of workforce and how we're able to manage care, particularly in regional and sub-regional and rural parts of Victoria and across all jurisdictions. You know, it's you know, for those nurse practitioners in the room, it is only, you know, prescribing is only one facet of what the nurse practitioner role is. So
I think we also need to work in partnerships, you know, where we partner with physicians, we partner with, you know, nurse practitioners, with registered nurses to provide better access to healthcare. I think to silo ourselves into our specific roles and disciplines, we do our patients a great disservice. We had a question, I think, down here, and I'm also conscious of the time. Perhaps we'll have, you know, two, maybe three.
I think I was
Okay,
next.
Snez,
Okay,
sorry.
thank you. Amazing kind of presentation, and I'm enjoying this panel discussion. So I'm going to do a bit of a detour, and I'm going to ask you about education related question, because I feel that this proposed RN prescribing might also trigger a chain reaction, which is related how we actually embed pharmacology curriculum into our entry to practice programs. Because significant review that I've done lately actually shows across the globe, not just in Australia, across the globe, US, Europe, and Australia, that there are significant inconsistencies in the way we teach pharmacology to entry to practice programs. So do you think that this could be also a triggering or initiating event causing all those downstream changes that regulatory bodies might actually implement?
Great, that's fabulous feedback, thank you. And I understand there's some work being done in New Zealand on that as well. I guess I can't answer on behalf of AMNAC because this is particularly related to accreditation standards, but the board approves those accreditation standards. And I do know that the accreditation standards are based around that national prescribing competency framework. And that's probably all I can tell you at the moment, but there are differences in AQF levels. I don't know, perhaps Jai can answer, you know, about the nurse practitioner, because I know, it's the mapping of accreditation is around those national prescribing competencies framework.
We are talking about our prescribing workforce, so they're going from entry to practice into kind of this level. So are we providing enough education in entry to practice program that we can actually create safe?
So
It
high,
shouldn't be at the specialist level.
yeah. So I know the higher education providers that will be offering or that will be able to offer courses for designated RN prescribing. They have to have certain pharmacology and pharmacokinetics and therapeutics embedded into the undergraduate program. So not anybody can just set up an education provider and be able to offer designated RN prescribing. That's really a question for AMAC, but I do know that, yeah, that's already embedded in the undergraduate program. And there's certain higher education providers that will be exempt from being able to provide that because they don't have that embedded in the undergrad prog.
I'm going to come to the lady in front and then we'll go to the lady behind, and then I think that'll have to be it, unfortunately. I knew this was going to go off.
I think my question is pretty similar to what's the previous question, because you know, with the nurse practitioner, they become a nurse practitioner. They have to do a master in nursing with a pharmacological subjects, which is quite difficult. And And then after that, they need to have the endorsement for at least a year to actually get into those advanced patient assessments to be able to prescribe anything. So with the nursing prescriber, so how could they maintain the quality? How could they, be sure, and how could we be sure they prescribe something that's, not going to cause any other consequences? So this, I think, whether this has to be, coming a long way. And then if this happening, if they're going to be like, are they going to take over the opportunity for the nurse practitioners? Because currently I know that there hasn't been many nurse practitioner positions founded.
Do you want to? Oh, I can tell you that there is a difference between the AQF levels. So it's a postgraduate certificate for that designated RN prescriber. So you just can't come straight away from, entry to practice. You need to have that 5,000 hours and you need to have 3 years clinical experience or 6 years when you apply for endorsement. And there are differences in the accreditation standards from the RN, obviously, to the AQF level 7 to then the AQF level as a nurse practitioner. And those accreditations have been mapped clearly to that qualification framework.
And I think to speak to or address the second half of that question, it's really around what we do as a healthcare profession to advance our scope. Our future of healthcare will see demand like we've never seen before. So this is around registered nursing, working at the top or the optimal scope of practice, and then the changes that we'll see across multiple different craft groups because of that. The role of the proposed role of the RN prescriber is very different to the nurse practitioner.
We'll come to the lady behind you and then we might need to stop there, I think.
Thank you. I've come along to this today. I feel I'm in rarefied atmosphere because, of course, I was on the Ministerial Committee for Nurse Practitioners, part of the driving group to get that. And I spent a year sitting between the AMA and the RACGP, which I've survived. I was extremely keen to see nurse practitioners in primary and public health, which has not happened. I think you've been curtailed by the funding available, by the recognition. But I'd like to raise 3 of the major points which were not resolved in that committee. One is demonstrating that there will be no harm. And I think you need to know in Australia, the level of medication error has not shifted since 1995. It's between 11 and 18% in most facilities. I've been working in Indigenous health without doctors. I give my right arm for a doctor, but we just didn't have them. So we've been using the CARPA and PHCC manuals, which are excellent. So used to telehealth. I think it's weird that you think it's odd or new. And we were 2.5 hours by plane to get anything in. And the other thing that I'll raise, because it came out in my research, is the varied use of the terms policy, procedure, protocol, and evidence-based guidelines. You're going to have to make up your mind if you're going to demonstrate to the patients that they're not, at further risk. And I'd like to see that come out. And can I tell you, you've left out one of the schedules. Who put the schedules up? You've left out Schedule 11, which is prescribed medications in Indigenous communities. You're not allowed to prescribe them to children anywhere else. Look, I'm thrilled to see it, but I can just see the conundrum now about a registered nurse prescribing. We went through so much to get nurse practitioners prescribing. And are you sure it's to the benefit of the patients, really? I mean, can you really demonstrate that, do you think?
Thank you so much for your feedback. Gosh, that's a long question. Look, it's great feedback, and look, even like globally, the evaluation of designated RM prescribing, there is very little. So I have my trust in the great work that's being done by Flinders and Amanda Fox in implementation of those strategy tools across the board, and evaluation, because even in like New Zealand, where RM prescribing has been introduced for a long time, in the UK, there's very little research on evaluation, but in comparison, they talk a lot about safety and efficacy, and there's no difference between RM prescribing and medical prescribing in safety and efficacy. That is globally, that's what the literature says. I guess, as I said, hopefully, I think this is a really innovative proposed strategy for our profession, and it's very progressive. But yes, I guess those evaluation tools are still to come. So hopefully, maybe in 2 years, we can meet back here and have that conversation. And hopefully I've got some data for you to say, yes, you know, this is really worthwhile and here are some numbers. But yeah, I agree that that's one of the evaluation tools that is missing globally. And yeah, I appreciate your input. Thank you. That's great feedback.
Thank you. I think we could probably still be asking questions in another hour's time, but we might have to call it because we're well over time. Clearly, like Emma, my timekeeping is not that great either. But I was pretty keen to give people an opportunity to, and John's sniggering about that too, because he knows well, how terrible I am with timekeeping. I was really keen for people to have an opportunity to ask questions, because I think this has been quite a thought-provoking and kind of provocative topic, and it's an exciting, I think, shift for registered nurses in Australia. So thank you everyone for coming, but I would like you all to thank our panellists. They've been fabulous, and I think invited us to really think about what this might mean in our own practice and our own health services. Before we close completely, I do want to just say that we will be sharing the details for our seminar series and other events for next year very shortly. So if you've registered for this event, you'll get those details, and we'd love to see you all again next year. I'm also delighted to invite you to the Department of Nursing's end of year celebration, the 2024 Nursing Ball, which is hosted by the Melbourne University Nursing Students Society and open to all nursing students, alumni, staff, partners, friends, anyone you want to drag along. And that's on Friday the 13th of December. I know. So again, on behalf of the RMH, Peter Mac and UniMelb nursing teams, thank you all for coming. And again, I'd like you to thank our panellists again. We do have a gift for our panellists. So I'm going to ask Cara from Peter Mac and Yvonne to join me, and Kirsten, if you can also join me, and Kathy from the University of Melbourne. Yes, no, that's you too, Kirsten. For those of you who can stay on, there are refreshments outside, and it's an opportunity then to keep grilling your panellists, chat amongst yourselves, and also just talk about what you think the implications are with colleagues. Thank you all for being here. Yeah, these are good. Great questions. Yeah.
I'll just put up the photo of the starting. Yeah.
Thank you.